Hello, everyone. Good morning, buenos días. It's my pleasure to be here with you today. I want to thank Felicia and the organizers of this event for including me. As a reproductive health expert, the field in which I've been working for more than 2 decades, maybe 3, this is a wonderful opportunity because I will be able to talk about women's cancers in a much broader context. And integration is another topic that is very, very dear and important to me. And maybe the first example of integration I want to highlight is that Felicia's and my thinking are very integrated. In fact, many of the things she said I was planning to cover, so I will be briefer than I expected. But this is wonderful because I will sometimes add a little bit of information or talk about the same thing from a slightly different perspective. So this is the outline of my talk. I will talk a little bit, very briefly, about how the vision of women's health changed over the last 4 or 5 decades, because I think that explains to a great extent why we're working in silos, as Felicia highlighted. Then I will talk a little bit, very briefly, about women's burden of disease, because Felicia already covered it. And I will talk about how to integrate women's health care. And again, I will speak briefly because the diagonal approach has been already addressed. And I will also talk about women and health, a concept that Felicia, Julio, and I developed almost 20 years ago, in fact, and that is the name of the program I lead at the Harvard Chan School of Public Health. And Felicia and I were members of a Lancet commission that comprehensively discussed women and health and the evidence that supports that concept that was published last year. And I will end up with a few recommendations that I think are important. So just to refresh our memories, it was in the 60s when child health and family planning attracted the attention of development experts and global health experts around the world. Women were considered at that time mostly as vehicles to improve children's health, which is something that we definitely do, both from a biological and a social perspective. But at the time, women's health needs, their own needs, were not taken into consideration as they should have been. Rather, women were considered like vessels. If a woman's nutrition was improved, that would help the fetus to grow and become a healthier newborn. And if women's nutrition was better, breastfeeding would be more successful. But nobody seemed to think so much about women's health and nutrition as a right that women had. Family planning was a matter that concerned policymakers a lot because population was growing so rapidly and the world was about to deal with a population bomb, as Paul Ehrlich called it at the time. And again, women were thought of as the individuals who would use family planning, contraception, to reduce population growth, but their own rights were not taken into consideration as they should have been. So only a few years later, maybe 10 or 15 years later, maternal health became a focus that, in fact, is still very much an area of focus that Felicia alluded to. And that was in part the result of a paper that Alan Rosenfield and Deborah Main published in the Lancet in 1985 that was called Maternal Health and Neglected Tragedy. Where is the M in MCH? Meaning, where is the maternal component in the maternal and child health programs? While that paper attracted the attention on maternal health, that continued through the Millennium Development Goals in the year 2000 and beyond. And another important event that attracted that, or strengthened that focus, was the launch of the Safe Motherhood Initiative that maybe for the first time highlighted the needs of the mothers, not only as the vehicle to improve the health of her children. In 1994, many of you may be aware of what happened in Cairo the sexual and reproductive health paradigm was embraced by most countries around the world, and that was the first time when women's cancers became part of a larger construct, in this case of sexual and reproductive health. However, in spite of the fact that it was mentioned there, it was a neglected component and still is in sexual and reproductive health programs. Not much attention is paid to women's cancers. So what happened most recently? Women's health became an area of much broader focus. And now we recognize that women's health goes well beyond sexual and reproductive health. Maybe someone can give me a glass of water. Oh, thank you so much. So now I think there is a growing awareness. Thank you so much. That women's health is not limited to sexual and reproductive health, that women have their own issues that are a result of their biology and their reproductive function, but that they also share many problems with men, including many forms of cancer. But however, because of gender-related issues and because of poverty, they face challenges that don't affect men the same way, and I will provide some examples of that. So, in spite of this more holistic vision these days, women's health is still very much considered in silos or taken care of in silos. And some of the phases of a woman's life cycle and some of the aspects of women's health are given more attention than others. So we are promoting a life cycle approach that hopefully will reduce those divides that also Felicia alluded to. So we believe that women's health needs to be considered throughout the life cycle, that opportunities and challenges, in fact, accumulate over our lifespans. Of course, women and girls have their own they're very unique challenges throughout their life cycle because of biology and because of gender. But each stage influences the health and well-being over the next following stages. And that depends on the opportunities we have to access prevention and to access early detection and to access management of our health issues. Sometimes our own health even affects the health of the next generation, and it should be considered as a continuum, not as something divided into phases. But it's sad to see that sometimes one phase takes precedence over others. So the health of the girl is what is the focus of a particular program, or the health of an adolescent is the focus of a particular program, without considering that adolescents' health, particularly healthy behaviors, the lack of use of tobacco or the limited use of other or exposure to other risks will benefit the health of women much later in life, not only during adolescence. So positive and negative effects on health accumulate over time. Felicia already talked about how the burden of disease of women is changing. Until not too long ago, women's health was mostly characterized by maternal mortality and by sexual and reproductive health issues. Not that those have disappeared. That's definitely an unfinished agenda. But now non-communicable and chronic diseases are taking a very, very important part of women's global burden of disease. I hope you can see this graph from wherever you're sitting. I don't see how well the slides can be seen on that screen. But what I'm trying to show here is that except in the very early ages of life, the two bars at the bottom, 0 to 4 and 5 to 19, in all other stages of women's lives, the orange bar, which represents non-communicable diseases, is the larger one. So women's health now is dominated by non-communicable and chronic diseases, which is something that would have looked very differently if we had had this same graph not too long ago. And as Felicia was also pointing out, this is not anymore an issue only in developed countries. It's also very much an issue in developing countries. Each of these bars show a different country, some of them developed, some of them not. And we can see that NCD's death rates are very, very important even in very poor countries like Ethiopia, Uganda, Nigeria, and India, which are the last four columns in this graph. The Americas that I know are very well represented here, me da mucho gusto, are not an exception. On the contrary, and this graph you will not be able to see from wherever you are sitting. It doesn't matter. I just want to show that this very, very long, well, I don't know how this pointer works, but the very long column at the top, the blue one, shows that 85% of deaths are due to non-communicable diseases in the Americas these days. So we all need to change our vision and the paradigms under which we work because the situation is changing so dramatically, and this is something that hasn't happened yet. The growth of non-communicable diseases is not surprising, however, because the risk factors have changed so much over time. And this is another example from our region that looks at obesity and overweight in selected countries. And while the columns show the percentage of the population that are affected by obesity and overweight, men versus women in some cases when the information is disaggregated by sex. But without spending too much time on this graph, I can just share with you, and it's something that I know you are all aware of, that the percentages are astonishing. There are some countries like Guatemala, Costa Rica, Mexico, and Panama, and many others, where the percentages of obesity and overweight are very, very high and increasing, and usually obesity is more common among women than among men. If we look at another risk factor like smoking, we can also, and these data are disaggregated by sex, we can also see that smoking is very, very prevalent, particularly among men, but also among women. And if we looked at trends over time, which is a graph that I didn't bring today, we would see that tobacco use is increasing among women. While smoking and lung cancer are not the focus of this symposium, I think it's a good example of, this is a good example of how neglected addressing the risk factors and the conditions that affect women are. This is not surprising. Girls and women are now the target of tobacco companies, and most of the advertising is focused on them. And tobacco use is advertised and promoted as something that will make women sexier, that will make them more attractive, that will help them with weight control and stress relief, and so many misleading messages that all of us here are trying to combat. So let me now say a few words about why women's health faces unique challenges, and some of these things have also been addressed by Felicia. First of all, because women's health combines the effects of sex and gender. So it's not just our biology that explains why we have breast cancer. Of course, that explains why we have it in much higher, with a much higher prevalence than men can have it. But gender also plays a major role. And Felicia referred to the fact that women may face stigma, that women may have a lower ability to go to preventive services or to, in this case, early screening services earlier, Women sometimes don't have the financial resources to go to those services that may save their lives, or they simply give precedence to the health and well-being of their families over their own, and they don't take good care of themselves, as John Cicada also mentioned. Stigma, Felicia referred to stigma. Stigma is a big, big thing. We all fear stigma, and it doesn't only affect breast cancer. There is stigma associated with family planning. There is, in some contexts, there is stigma associated with termination of pregnancy, even when abortion is legal. There is stigma about sexually transmitted infections. So if stigma was reduced, we would improve the health of women in so many different ways, not only associated with the stigma of mastectomy or the stigma of cervical cancer, considering that it is a sexually transmitted infection that produces it. Another way gender affects women's health is that sometimes women get later and less aggressive care for some NCDs. And that has been very well documented in the case of cardiovascular disease. Women's symptoms of cardiovascular disease are different than men's. Sometimes they are confused with anxiety attacks, with panic attacks, or with anxiety, and they are not, providers don't think of those symptoms as symptoms of cardiovascular disease. And women are sent back home because they were just nervous about something, and in fact, they were about to have a heart attack. So that explains that in many cases that women get a poorer care for a condition they share with men. Something similar happens with lung cancer. Providers in many places still think that lung cancers are men's problems, without thinking that women who now smoke much more and are also the victims of passive smoking would have lung cancer as a very important problem too. Since we are in a university, I just wanted to highlight that another important challenge that women's health face are the misconceptions about sex and research. There has been a lot of attention recently about this, the fact that in all types of research, from bench research, lab research, to public health research, female subjects, and not only women, but also cells, also animals, are included in research projects much less than men. And that has very important, or male, that has very important implications, because the conclusions that those research projects reach are applied to women, and sometimes they don't have the same effects, for instance, of a drug on women as they have for men. So sex discrimination limits the generalizability of those research findings and their applicability to women. And this is something that needs to be changed. The NIH in this country has recently adopted a new policy that makes mandatory the enrollment of female subjects. And we are now working with the NIH to try to promote among editors of the most important journals, health journals, to also mandate that findings are disaggregated by sex, and implications of research for women are highlighted. So women's health is facing neglect, in spite of the fact that women are in charge of most of the health care, both in their homes and communities, and as members of the paid health workforce. So this is a beautiful picture from Guatemala, from midwives from Guatemala, who are mostly women. If we look at community health workers programs in other countries, they are also 99% held by women. So how to integrate the approaches so the work of these women becomes more effective, and the work of everyone in the healthcare sector becomes more effective. This is critical and urgent because, as a nurse midwife recently said, A woman does not live her life in compartments. We need to do something to link all these different issues that affect different stages of our lives or different spheres of our lives. As Felicia pointed out, there are well-established mainstream programs that we can use as platforms to add NCD care and cancer care to. I won't spend too much time on this, but NCDs can be and should be part of maternal and child health care. Of course, in family planning, which is sometimes the first point of contact of a woman with a health system, NCDs should be talked about, should be mentioned as something that women need to be aware of. Same case with HIV/AIDS. HIV/AIDS provides a wonderful platform because although it's a communicable disease, it's a chronic disease. So many of the same issues that need to be taken into consideration for the care of non-communicable diseases have already been developed for the work on HIV that is a well-developed platform in many, many settings around the world. And even NCDs and vaccination. There are very well-developed vaccination programs, but they usually don't include the HPV vaccine in countries that are not able to afford the vaccine or don't have the capacity to reach older children as the HPV vaccine requires. So Felicia spoke quite extensively about the diagonal approach, so I'm not going to address that now. I just want to emphasize or support that that's a very, very important opportunity to strengthen, or a very important approach to strengthen health systems. Just again, using the example of stigma very briefly, if we work with providers to make them more aware of stigma, and if we work with them on stigma reduction strategies, that there are many, we will not be helping only sexual and reproductive health issues, but also cancer and other non-communicable diseases care. Multiple benefits for users that Felicia already addressed: better coverage, better access, continuity of care, more efficiency in terms of cost and time. If a woman can get to a service and get the care she needs for multiple conditions, that will save her time and money. More privacy. If a clinic is not only for sexually transmitted infections, but is for women's health, women will not feel that they are singled out if they go to that facility for a sexually transmitted infection. And of course, well, in some cases, these integrated services have been evaluated, and they are usually associated with more satisfaction by the user, and multiple benefits for health systems as well that I don't think I need to cover now. So we need policies that are enabling, and the Sustainable Development Goals that Felicia showed on a similar slide to this one are now the global policy framework under which we are working. They were adopted a year ago, almost exactly a year ago, and these are now the global priorities in terms of development and including health. So now we have SDG number 3 that reads, ensure healthy lives and promote well-being for all at all ages. That is very encompassing, and in fact it provides a wonderful framework for integration. Also, interestingly enough, and importantly enough, it has one target specifically dedicated to NCDs that says that by the year 2030, which is the deadline of the SDGs, NCDs will have to be reduced by 1/3. This might not be terribly ambitious, it may not seem terribly ambitious to you, but it's going to be difficult to reach. And it's good to know that that target is there. Until last year, we worked under the Millennium Development Goals framework that didn't have anything on NCDs. So this is progress, but we need to go translate these very, very high-level commitments into action, and that's where the challenges lie. So with the Women and Health Commission that published the report that I was referring to last year, we developed this conceptual framework that shows that women are related to health in many, many different and complex ways. We are not only interested in women's health, we are also interested in how women contribute to healthcare as mothers, as sisters, as community health workers, as nurses, as midwives, as doctors. And both are very connected, both roles, both types of roles, the roles that women play as users of the healthcare system and as providers of healthcare. And both roles are affected by the same conditions, by the same social determinants and huge transitions like the epidemiologic transition, the demographic transition, and other transitions that we are all living under. So let me give you an example of that gray area between the two circles that tries to represent the overlap between the roles that women play as users and providers of healthcare, using breast cancer as the example. As you all know here, breast cancer is the leading cause of death of cancer among women. Cardiovascular disease is the top cause of death among women, but cancer is the second one, and breast cancer is the most important, the top cause of death by cancer. So from a health perspective, breast cancer is definitely a very, very important role. But again, women are not only users of healthcare services, they are also providers of care for themselves and for other members of the family and for the patients they see in their many different roles as healthcare providers. But gender represents a barrier, not only for women as users, but also for women as providers of healthcare. Women usually don't get to the same kind of leadership positions that men get, even if in medical schools and nursing schools and in the nursing profession, women are 99%. But even in medical schools now, there are as many women as men, but once they start their careers, they start lagging behind. And that's to a great extent because there are no policies in place that would allow women to integrate well their roles, their reproductive roles, their family roles with their professional roles. And that definitely contributes to them getting into less often into residency programs and into other career stages that would help them reach leading positions. So using breast cancer as an example, as I was saying, breast cancer outcomes and women's ability to contribute to their own health and awareness about breast cancer, early signals and the need to get a mammogram or whatever resources are available in their settings is affected by gender and by the neglect that women face and feel themselves. We think that by valuing women, informing them, and empowering them, we will help them both improve their outcomes and their prognosis in terms of breast and other cancers, and also help other women, either their patients or close women in their personal lives, better. So let me go very quickly, just to finish, through some of the recommendations that we have in the report, and I selected a few that I think are particularly relevant for the topic we are discussing today. We organize them around 4 topics: value women, compensate women, count women, and be accountable to women. So in terms of in terms of valuing women, universal health coverage, which is the most comprehensive and integrated strategy that Sustainable Development Goals promote, represents, well, a very, very good opportunity to address women's health holistically and throughout the life cycle. So countries that adopt universal health coverage should also adopt women as a priority, as a target population group, and that would represent a very good way to value women and their contributions. We need to develop those gender-responsive policies, and not only develop them, put them in place to help women overcome all gender-related barriers, and there are many. In terms of compensating women, in the Women and Health Lancet report, and Hector, who is probably here in the audience, Felicia had to leave for an interview, I think, was instrumental in developing a study, a sub-study within that framework that estimated the monetary value of women's contributions to healthcare, both underpaid and unpaid, and it's huge. I don't have time to talk about that now, but it's huge. Women's basically subsidy to the health system is completely amazing, and that should be made visible, and women should be fairly compensated by the care they provide. And compensated not only in terms of money, but also in terms of training opportunities, flexible career paths, and other ways to make women's fulfillment as providers a reality. Counting women is also an important aspect that we provided recommendations on. Very often, even in countries like this one, health statistics are not disaggregated by sex. Whatever information we have about healthcare, the healthcare workforce is not disaggregated by sex. So it's impossible to know, to really assess the gaps between men and women in terms of their own health and the care they provide if those statistics are not disaggregated. Felicia mentioned the lack of a cancer registry in Mexico, and I know that Alejandro will talk about that. I don't know to what extent that already is or going to be disaggregated by sex. But when something is biologically only related to women, it's easy to know how many women are affected. But when it's for a cancer or an NCD that affects both women and men, like lung cancer, we need to have this sex disaggregated data if we want to fully assess the situation of women. And as I said before, we also think that it's very important to mandate the enrollment of female subjects and women in research studies. And finally, be accountable to women. We need to establish the mechanisms to hold governments and societies accountable to women, and the indicators that will allow us to assess the evolution of different situations so we can identify the red lights, if we think of a traffic light, and address them whenever they happen. Thank you very much.